fact that we have to restart meeting late. We've obviously had that was one of our INs groaning.
Okay, that's fine. Oh, there are many gremlins in the system this morning.
Okay, thank you very much, everybody. Apologies for having to restart this meeting late. Dwi just yn mynd I checio cyn I ni gychwyn os ydy'r cyfieithu ar y pryd yn gweithio. A chi'n I weld os ydy'n gweithio? Nac ydy. Nac ydy. Right, diolch yn fawr iawn.
It works.
So it's working online but not in the room.
Working now?
It's working online and in the room.
Excellent.
Excellent. So, welcome, croeso, i'r cyfarfod bwrdd cyhoeddus yma o ymddiriedolaeth GIG Felindre. Dyn ni'n cychwyn chydig bach yn hwyr bore yma, oherwydd bod ni wedi cael problemau gyda'r cyfarpar, ond mae'n falch gen I ddeud bod y tîm wedi ynhachub ni. Diolch yn fawr iawn I chi. Dwi'n gwybod bod y pethau yma yn digwydd, felly diolch am eich amynedd a'ch dyfalbarhad yn cael ni nôl ar-lein. Diolch yn fawr iawn I chi. I'm going to start with apologies. We have apologies from Carl James, our interim Chief Executive Officer, and Kerry Doyle, independent member, both of whom are on leave, and from Carl Taylor, Chief Digital Officer, who is today attending the DCHW National Conference. Are there any other apologies that I haven't noted? No? In that case, I'd like to welcome a couple of new executive members around the table. First of all, Jill, wonderful that you're here with us for our first meeting as our Interim Director of Nursing, AHP and Clinical Scientists. And I know that you have been at Felindre before many years ago, so you're coming home to us. And you're coming to us from being the Deputy Chief Nurse at Welsh Government. And we're absolutely thrilled to have you. Welcome. And welcome also to Vicky Oxley, who's joining us as Director of Planning. She's joining us from Cwmtath. And we're really, really pleased to have you too, Vicky. Thank you very much. Welcome to Arshad Siddiqui, Senior Clinical Fellow, who is a surgery trainee. And we're really pleased to have you with us. To Bethan Davis, who's providing simultaneous translation. We may be joined later by Ben Legicario Lasunde, who's an aspiring board member and a faithful attendee at these meetings, and by Katrina Furby, who's the audit lead for Audit Wales. I think I've got everybody, is that right? Oh, no, I haven't. Lindsay Peddle, Patient and Carer Forum, you're here as well. So welcome, Lindsay. It's good to have you here. And yeah, welcome. So I don't think there's anybody else, and I'll move on to declarations of interest. I haven't been sent any declarations of interest. Are there any, please, that anybody wants to declare? No. In that case, we will move on to the minutes of the board meeting held on the 26th of March, and I'm going to go through this page by page. If you could indicate if you have any corrections or queries before we are happy to approve. So if we go to page 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14 and 15. No amendments. We're happy to approve? Yes, thank you very much. So that takes us to the minutes of the extraordinary public board meeting held on the 30th of April. And again, we will go through these minutes and identify any amendments or corrections. So page 1, 2, 3. Happy to approve? Okay, thank you very much. Gareth?
Diolch Cadeirydd. Ar yr ail dudalen, pwynt 2.1.
Ie.
Yn y drydydd llinell cyn y diwedd, dwi'n meddwl dyle'r y iaith weid bod yr Pwyllgor Strategic Development wedi cymeradwyo'r penderfyniad yn hytrach na just scrutinise.
Digon teg.
I'r dim.
Ie.
Diolch yn fawr, Gareth. Ie, mae hynna'n ffeithiol gywir. Diolch. Rhywbeth arall cyn bod ni yn cymeradwyo'r nodyn yma o'r cyfarfod? Na? A hwnna wedi cymeradwyo felly. We'll go on to actions. So I'm going to go first of all through the proposed close. And again, if we have, we'll do these by exception if there are any questions. So 66, 67, 68, 69, and 70, 72, 73, and 75. Are we content to close those? Oh, Gareth, it's an old hand, is it? Legacy hand. Okay, thank you very much. So we have two open. Lauren.
Sorry, Chair, I just pick up, was that the first paragraph in 210, which from the Strategic Development Committee? I didn't quite follow the translation quickness, sorry.
So going back to the minutes.
Yeah.
It's been approved by that committee.
Endorsed.
No, because the committee can't approve.
Endorsed.
Oh, endorsed.
Endorsed, I mean,
Cymeradwyo.
yes, endorsed.
Yeah.
Yeah.
Cymeradwyo is endorsed,
Right,
yeah. Sorry.
Deal.
Okay, so we've got two open actions on the action log. We've got action 71, which is embedding the donor and patient voice across the trust. And we have an updated deadline for that action based on the fact that we obviously have a new director of nursing in place who will be looking at this. So if everybody's content, we will keep that open. And we have another open action, which is action 74, which is an update on digital resource requirements, and the reason for the keeping that action open is similar, that we are going to be coming back to that in July, and clearly we are having very active discussions of how we increase the profile and the focus of digital within our governance and decision making structures as well. So we might also be able to pull that in. Content? Okay, thank you very much. Are there any matters arising? Okay, in that case, we'll go to our staff story, and welcome. Please introduce yourselves, and we're really thrilled to have you here, and I'm sorry you had to wait for us. But let's hand over to Elizabeth and Joanne.
Thank you for having us. So good morning. My name's Liz Davis and I'm here with Joanne Gregory. We've been working with patients with genetic hemochromatosis, who I'm going to call it GH from now on because it's a big term. We've been working with these patients to turn their treatment in the hospital setting into donations with the Welsh Blood Service. So unfortunately, a patient donor advocate isn't able to be here today, but he has worked on producing a video for us. So rather than listen to me, I'm going to ask if we can watch the video that Grant has helped us work on. We're using this as an educational tool to support other people like him with this condition.
Can I check as well that everybody online can hear? Or whether we need the microphone closer to you.
Yes.
So let's
Good.
you know if you can't.
And the audio isn't working. The audio isn't working.
Can you Tracy for us what the story was? We'll circulate this with the recording of the board, and we will also
Play it and I'll just talk over.
Oh, yes.
That might be,
yes.
at least you can see Grant then. That's our owner.
There are subtitles on the video as well, so that will help.
Yeah.
Into that now. Okay.
It is available in English and Welsh. Go on to YouTube, it's available.
You're prepared for all eventualities for the video. Fantastic.
Absolutely.
Right.
So this is Grant, and he's going to talk us through his story of his journey to being a blood donation. This is one of our nurses on clinic.
The aim of the video, we would like our health board colleagues to use this to inform our patients who are potential blood donors of what the donation process involves. We did a lot of work regarding the information that that's available for them to give to their patients, and found there wasn't a lot there. So we decided to do some work to ensure that there was that information there, so it gives them up-to-date and contemporaneous information at the point of need. And one of those has been the GH video.
Can you tell us how you're sharing this with colleagues?
Yes. So I do have this later, but we've put together a SharePoint page which they can access. And on that SharePoint page, we have a number of different information sources for them to use. Also, what we've done is we've put together, because they are working in a clinical setting, haven't always got access to IT, but most people have access to their phones. So what we did was we've put together a laminated sheet, quite a simple idea really, which we did in conjunction with our health board colleagues. So these ideas have come from health board colleagues, patients themselves and donors. So the laminated sheet has QR codes on there, so the patients can access the video directly. And it's conducive to having those conversations as well. What we want to encourage our health board colleagues to do is feel confident in the information that they provide into our potential donors, that they are well informed before they come across to us. There's no misinformation given really. And yeah, just to try and encourage them to donate if they should wish to do so.
Also see that we've worked with one of the nurses from our local health board who is actively encouraging her patients to come over to the Welsh Blood Service. So we're looking at demystifying what it's like to become a blood donor.
Just on that point with Liz as well, what we've done is that we've asked our colleagues from the health board, in particular we were working with COMPAF at this point, to come across and to have a look at the blood donation clinic. Also what we did was we asked them to come across to welcome some of their patients into this clinic so that the transition would be smoother for these patients as well. And that's worked particularly well. So we're going to continue to do this and have that partnership process. And we've also done the same in Bexley Cadwaladr as well on our Wrexham clinics, as we have another one of me there, Alison, who's working on a donation clinic, but also doing a similar post to myself, who also welcomes the staff and patients across to us to make that transition process really smooth for them.
Are we able to go back to the slide?
Presentation.
Alternatively, I could share if that's easier.
No, it's there.
So if you can go to the next slide. So we also held a stakeholder event 2 weeks ago where we had nursing and medical teams from across Wales, from hospital teams, to discuss best practice in how to care for people with genetic hemochromatosis. Grant very kindly also came to that event and told us his story, where he was previously a patient in Swansea Bay Health Board and then moved over to the Welsh Blood Service for his donation. So these are some of the slides that we're presenting on his behalf. And his title was Quality Street Made for Sharing.
Doesn't want to know.
Just to point out, we've worked with Grant a lot in some of the stuff that we've been doing, because he had some really great ideas. So we've passed quite a lot of the ideas that we've had through Grant as well.
So, bit of background story of Grant. He's recently retired. He's 63 years old, and obviously his best interest is he spent 20 years as an improvement manager in NHS Wales. So he was really keen to help work with us on this. So he was diagnosed at the age of 39 back in 2003 when he started attending Swansea Bay Health Board. But he's been with us in the Welsh Blood Service as a donor since 2020. So next slide. The next slide is really important. This is Grant's slide where he presented his two pathways, firstly in the hospital and then as a Welsh Blood Service blood donor. So you can see on the left-hand side, his treatment in Swansea Bay, he's calculated things such as how long it takes him to get in contact with his clinical team in the hospital, up to 21 phone calls on some occasions to speak to the right person. He has to go to Singleton Hospital for the venesections, which is his treatment. So that is a fair distance from his home. So this travel time, his circling around the hospital car park, and all the follow-up appointments associated with it. So Grant has calculated that time for one treatment in the health board for him is 4 hours and 25 minutes. Compared that, and the final important thing is the final part there is when his blood is taken, it's incinerated as clinical waste. So on the right-hand side, Grant has mapped out his pathway with the Welsh Blood Service. So he can book his appointment online, so no delay. He'll select an appointment which is close to his home and at a time that's convenient to him to fit in around his work or his social life. He then travels to that session. It's swift. He's happy with the process. Of course, for him, the benefit to society is much better. His blood gets to go to somebody who needs it. So the time for that donation is 1 hour 55 minutes from Grant's calculation. He's turned that into the equivalent time in months, 4.3 months in the hospital setting of his working life. Is put to donation, treatment in the hospital. And if he's a Welsh Blood Service donor, that's 1.9 months. It's a considerable difference over what he called his blood donation career. If we go to the next slide, Grant has also sort of looked at the benefits to society, and he's calculated that his treatments.
Wait, I have gone to the.
That's okay. It is at the bottom of this slide here anyway.
There we go.
Yeah, so total number of treatments over his blood donation career, 152. And when Joe and I sat down with Grant, we said, well, it's not just 152 blood donations, because in the Welsh Blood Service, we centrifuge the blood and we can split it into 3 further components. So red cells, which is often used for people with anemia or cancer, plasma used for people who've suffered from burns or blood clotting disorders, and platelets, again, often used for people who are undergoing cancer treatment. So, rather than just 152 donations, that's potentially 456 blood components, or one unit can also be split down further into 6 small packs to treat 6 babies. So Grant has calculated that he can potentially support 912 babies over his blood donation career, which I think he was quite touched at. That was quite emotional for him. I'm going to hand over to Joe now.
So we've done lots of work, lots of co-production. Yes, please, next slide. So we've just put together some quotes. So we've done a recent donor survey. We did it over, so we've been doing a project over the last 8 months. So a lot of work has been done, lots of co-production. One of them has been a donor survey because we wanted to find out what are our donors saying about our new referral pathway that we've put in place. A referral pathway we've worked with our donors and our patients and our health care professionals in the hospital on. So these are some of the things that they're bringing up, which are great. So obviously the big win doesn't get wasted. They've got this condition. It's a condition that obviously nobody wanted to have, but actually it's put to good use because now they can donate blood as well. So provided they're eligible, they're able to donate this blood back. So it's giving something back. And I think for them, that's a major win for them with having this condition. Some of the other things they brought up, easy to park, because a lot of our clinics are much easier to park. They have designated car parking, especially we do at Talbot Green, but our other clinics as well, because we do that for our donors. So we book venues on that basis. That they like the clinics, they like the fact that they're not overburdening the NHS, and it's really easy for them to book appointments because they do this online. One of the things Grant did say in his presentation was it took him 21 times to get through, for him to get through to his healthcare professional to book a venesection treatment. So again, you know, that's much easier for them. So that's the good stuff. On to some of the not so great stuff, but stuff we're working on. So we are working with our donors on this. So the next slide I've put in red, just some of the feedback that we've had. I like this one in particular, the WBS IT system. So one of our donors that I've been talking to on a regular basis that comes into our Talbot Green clinic, because I go down to see them, has said, your IT system is not very good, it's not conducive, and he's an IT expert. We've had lots of conversations regarding this. And he said, it's been bugging me for the last 3 years. I've been coming, you know, and it's true, and we know this to be true. But we are working on a new IT system. So we've decided, let's bring him in. I've asked him, would you like to come in and have a look at what we're working on? And this might help us because we'll know from your point of view what would work. So yeah, that's been really good actually. So it's good to do these surveys as well because they do bring up some points that we do need to work on, and we know that. Again, the registration process, there's some stuff we're working on in the background and working a lot on the operational side of things and making sure it's smoother. And this has been part of that pathway going forward. We've also brought in an e-referral system. This is something that we asked via a benchmarking survey to our health boards at the start. We found out that there were lots of reasons why they weren't sending these donors in to us. We were averaging about 3 a month. So now, since we brought in our new e-referral system, we did have a patient agreement form that the patient would have to sign. It would have to go to the healthcare professional. Sometimes they were doing telephone consultations. It was taking about 3 months for a donor to get through that pathway. So we do e-referral now. They have a declaration form that they go through with the patient, and we find it's much better for the consenting process and things like that. They have those conversations with the patient. So that's really important, and we've streamlined that. So just to bring this back to what we're doing here, basically turning treatment into donation. And we really like this phrase because it really helps to bring that home to everybody, really, that this is what we're doing. It's safe. The process is safe. It's been risk assessed. Everything is good. This is what we're doing. So you've got your patient who wishes to become a blood donor and they're eligible. They come across to us. The blood is then utilised. It's not discarded. So that's a circular economy. And then the patients who need it the most, they are receiving that blood. And as we know, blood shortages the last few years have been something that we've had to challenge, really. So it's something that we're working towards. So these donors are a great donor pool for us. We just needed to make that a much smoother process for them. A lot of the work that we've done, I won't go through it all, but basically what we try to do on the next slide is provide a person-centered, positive patient outcome approach through co-production. It's been really, really important. All the feedback we've received from the donors, patients and health board colleagues has been so important, which is why our stakeholder event was a really, really useful event for us as well. So we charity Hemochromatosis UK as well. I ask a lot of staff if they want to go on these sessions. They do education sessions, and our staff can go and attend these online within an hour session. And then obviously we've improved our information resources because we've got our SharePoint sites, which is really important. They can have those conversations then with their patients with that information there, and they feel confident in the information they're providing. We've also got an inbox, which is previously we had an inbox which went to a number of different queries came in there. We've made that a generic genetic hemochromatosis inbox now. So all the queries get put in through there and is streamlined. Our e-referral system has streamlined the process as well for our patients. And we've worked with colleagues to develop that as well as our patients to see how they get on and how much that's reduced the referral time, and it's reduced it substantially. Okay, and just moving on now to Grant's quote. So we asked Grant if he would provide us a quote for attend today. This here you see is the text message that Grant receives, or all of our donors receive, once their blood has been issued to the hospital. They will get this text message to let them know your blood's been issued, basically, and that this is where it's gone. And for them, that is quite an emotional process, because they're getting this and they're like, wow, my blood's not been wasted. It's actually going to a patient, and a patient in need. So Grant said, seeing the changes happening to people like me doing blood has made me feel quite emotional at times. It has always made perfect sense to me that my blood could be used to help others. During my venous sections in the hospital, I would often be sat near to someone receiving a blood transfusion. Knowing that my blood is now going to help someone who needs it is very fulfilling. And Grant has said when he was in the stakeholder event, he did feel quite emotional at times, because he could see the amount of work that's gone on within Welsh Blood Service for patients like himself, really.
Questions?
I think that was inspirational. So thank you so much. Jill.
Just a quick question. What's the potential with this? So how many people are living with genetic hemochromatosis in Wales?
So,
Accessing the service?
sure. So it's the most common genetic condition in Wales, commonly known as the Celtic curse. So 1 in 150 people have the genetic mutation. It doesn't necessarily mean that they will definitely go on to get the sort of symptoms associated with the disorder. But approximately 50% of men do, and 20% of women. So there are thousands of people out there. Many won't necessarily be diagnosed, but the genetic screen is in place, and there's more genetic screening going on, particularly with increased awareness. So there's a huge cohort of patients that we could be helping.
I think at the start of the project, there was originally, well, we've had 150 then at the start of the project that's come on to us as new referrals into the system, and that's getting more and more every day, really. Last week we had 13 new referrals within that. I think it was a week and a half period. So, with the engagement that we've had with the health boards as well, and donors, because we're patients, we are trying to promote it and bring that awareness as well, so they understand they can donate if they want to. It's an alternative treatment pathway for them, but it obviously benefits society. So yeah, we are having quite a few now come through the system, which is great.
Thank you. And then Hilary.
Thank you, Chair. So I think it's a no-brainer, obviously, from patients and to protect the supply of blood. And I think that the team have done an awful lot with the nudge process. But I wonder now if we need to have some clinical conversations across the health boards, because actually in the fullness of time, and we could set a date in the future, whereby we could move all of these patients from health boards to the Welsh Blood Service. It would take a phenomenal pressure off health board colleagues, and actually it's a better patient experience. So I think we probably need to start having those conversations, maybe through the I'm happy to do it through the COO group, but through our professional groups, and agree what that would look like, and do a staged approach so that we can transfer patients away from health boards.
Joanne, thank you.
Wait, can I just, they do have to be eligible blood donors.
Yeah. Hilary?
Yeah, sorry, just a quick one. And all the people around the table probably know, because I bang on about it enough, I've got GH, but I can't donate, unfortunately, at the moment. However, it is being spread, the word is being spread in Hywel Dda Health Board, so they are aware of it, but I agree with Anne that there is a lot more that could be done. Just one little technical question for me, because something that they've done for me in the Health Board, and I'm not sure whether it's just for me, but I donate by cannula now. Is that something that you can consider? Because a lot of people don't like the big needle.
Probably not, because we do have a certain amount of time that is required for this blood to go into the bag, etc. And that's to for the quality of the blood product. Really, there's probably not something, but I'm sure we could ask colleagues to look into something really.
Thank you. Vicky, then Matt, then Lauren, and then we'll draw this to a close.
In my question, I was interested in the improvement slide that you'd got in terms of the various areas. Living in Mid Wales, I noted the person who'd moved from Mid Wales to South Wales felt he'd got an improved service, but from an equity point of view, having been to the Welsh Polyclinic and areas up in North Wales, I'm wondering why that is. Yes, it's a much more rural area. I understand that, but actually, what do we need to do to make that improvement?
Well, as Jo mentioned, it is something that we're looking at as part of this project. I think we tend to target areas with more sort of dense population so that you can populate the Welsh Blood Service clinics. But if we do identify that there are pockets of with certain conditions in certain areas, then we could potentially put on more clinics. But it's also about sort of balancing, can we fill the blood donation clinic?
Yes. Yes, it's a practical element. And so how do you get the information that informs where are pockets of patients with GH?
That's one of the difficult issues. I've been trying to look at data, which is not reliable. Powys in particular is quite difficult because they have contracts with England. Some of their patients go to England, so that's probably the hardest health board for us to work with at the moment, but we are trying to engage. I've had a couple of conversations, but it's something that we probably need. It's probably not within my remit or full understanding, but we probably need a little bit of help to do some modelling as to are our clinics in the right place and at the right frequency to support people.
Lovely, thank you.
Matt?
Yes, it's a little bit of a repeat, but this project is part of the value-based healthcare programme in the trust. So raising it through the Value and Sustainability Board will be important. I've already flagged about each professional lead trying to do it through their fora, but also any engagement we have with our commissioners, like NHS Wales under pressure, as we've all described. This is already benefiting capacity release in health board, but it could be much bigger if they all engaged in a certain way. And of course, the sustainability stuff that you guys have flagged as well in terms of carbon footprint and not incivility. But we don't need to.
Thank you, Matt. Lauren?
Yeah, and thank you very much to Liz and Joanne for taking us through it. I mean, we touched on it, but just to highlight one of the other aspects linked to value-based healthcare in terms of sustainability. So in terms of the mapping just on the clinical waste, there's 0.5 kilogram of carbon for every bag of blood that is incinerated. So that's not even taking into account the production of the bag and manufacture of the bag in the first place and the transport. So just from the 6 months last year, we've already saved 250 kilograms of carbon through this. And it's one of the elements of the project that's been highlighted through the sustainability network as well. To Anne's point, this is all different peer group networks that are involved in the various benefits that we can pull together, as Matt's saying. And Chris Brown, who's the value-based healthcare director in P&I, who attended the stakeholder event when he was doing his social updates about it afterwards, he really brings a lot of this to life. So to see that from the Welsh Government sponsor of this work, raised on social media as a result of your stakeholder event was fantastic to see as well.
Thank you very much. So just a couple of things from me. First of all, in terms of one of the open actions we have, which is for Jill to be working on patient and public involvement, this is a brilliant example of how we do this really well within the organisation. And there's a lot of learning, because our discussion around that was we tended to collect satisfaction data, but our ability to actually engage patients and donors in service improvement, because they are the ones who are having that experience, is something that we need to bring in. So if the board could see how we do that. The second thing was the improvement methodology that the Welsh Blood Service uses, which I think, again, has got a lot to teach us across the organisation. And the third is that aspect of value-based healthcare, which Matt has said. So there's the practical and the operational element, but there's also, this is quite an important strategic illustrator of some of the things that this board is looking at. So I want to thank you very much. I'm sorry, I didn't introduce your colleague who's working with you on the audit. Do you want to introduce yourself as well, because you've come along? And
Hi, I'm Vaxica. I'm one of the medical students at Cardiff right now. It's part of my SSC project to be doing a write-up on.
Good, excellent. That's really good. Good. Thank you. So thank you all very much, and this will be shared more widely, and I'm sure others in this room will pick up those wider issues with you. Thank you. Okay, so I'm going to go on to my report, and in a sort of quite a segue really from what we've just heard, I just wanted to tell everybody that it's the 2nd anniversary of the publication of the Infected Blood Inquiry this week. That was a huge milestone for all of the NHS, particularly many hundreds of thousands of people who were infected and their families. And it's been very much an opportunity for thinking about them and thinking about what we have been doing since then to make sure that it never happens again. Alan Prosser, the director of the Welsh Blood Service, attended a memorial service in London earlier this week. And it is a symbolic milestone. And it struck me that this board could perhaps benefit from an update on the way that we are managing the consequences and the compensation scheme from the Infected Blood Service in the future, because it's an incredibly important piece of work, and very emotional really, that we should be at this stage. So I wanted to reflect on that today. And that's not in my report. Additionally, not in my report is that obviously since the last board meeting, we have had an election. Now have a new cabinet minister for health and social care, which is Mabon ap Gwynfor. The ministerial team are in place, and the support team are being pulled together now. The chairs of NHS Wales organisations have written collectively to the minister, inviting him to join us at our chairs meeting on the 23rd of June. And we as a board will also be writing and congratulating him and his team on their appointment. And we will be looking for opportunities for the minister and his team to be visiting us, as well as the other local elected representatives that we have. And you can imagine it's incredibly busy for them at the moment, because it's a very intense period of induction into their new roles. But we are clearly, that is very much on our minds at the moment, and we are focused on that. I'm going to take everything else in my report as read. And if there are any particular questions or issues, I'm very happy to take them. Are there any? Yes, please. Thank you. No, if not, we'll move on to Jazz. So I should have said is obviously here as Deputy Chief Executive in Carl's place. I'm going to hand over to Jazz.
Thank you, Chair. So you've all got the report that clearly is Carl's report and the activity that he's been up to since we last met at board. But I wanted to just put my lens on it and bring in one personal experience also that's happened in this time. I think, on the theme of us being an organisation of specialist services, events that point to this. Firstly, the visits to the new Velindre, which have happened. With our chair and senior colleagues from the health boards, really important in kind of setting the ambition for us being, providing specialist services for cancer. And the benefits here to our population that we serve, and also the opportunities for partnership, for research, for innovation, setting that out. Secondly, Carl attended a meeting of the Federation of Specialist Hospitals, which we are members of. And this was a meeting in March where the focus was on opportunities for artificial intelligence for specialist hospitals. What does it mean? And how can that translate into our plans? And the third event that I wanted to share was one that a few of us were on the Friday, 15th of May, which was last week, I think, which Anne had organised. This was a trip to UCLH, University College London Hospitals. And we had the executive triumvirate, which is Anne, myself, and Jill, alongside the divisional triumvirate, which is Kate and Emma and Caris, as well as Carl Taylor, our Chief Digital Officer, visiting UCLH. And I think we were really privileged to meet the Chief Executive Officer, David Probert, and members of the board, and in particular, his medical director for digital. And it was really inspirational. I think others may want to say one or two words on it. I think for me, it was about a very clear strategy that he set out for the board and the organization, which was absolutely underpinned by values. The values of the organization were ran through the thread of everything they did, including interview processes, etc. So we heard from him, and then we saw what good looks like in terms of delivery of cancer care in live. Their SACT services in particular, which was one rather large space. But what struck me was the lack of differentiation between the service, the patient having treatment as part of the service standard of care, and having it as part of R&D, and that true integration of what we could aspire to do. So lots there that we'll come back to you on from that. I think that the second theme from the paper is really around readiness. There was an away day with the senior medical leaders, with some of our executive colleagues, Matt, Sarah, and Carl, and we were talking about the future, the clinical model, the preparedness to get into our new hospital, and also we heard from Edwin about the importance of the apheresis service, and this real sort of integration also of the blood service and the cancer service and what that could look like. And there's a reference to the project board, Readiness Project Board, which has met twice and is really trying to get a rhythm now in place, integrating operational and strategic elements, troubleshooting, and new terms of reference to reflect that. Thank you. Any questions from people?
No? Thank you very much. And thank you, Anne, for organising these visits, because it's very important that we look up and out and that we're looking at, how we benchmark ourselves and develop. So, yeah, thank you very much. Okay, so that takes us on to the performance management framework. And Vicky and Anne are going to lead us through this and take us to those areas that they particularly feel the board should focus on. And I will be doing the same with Matt on the finance element of this. So
thank you. So if I introduce it, then if I pass to Anne, if that's all right for the. Sorry,
two Vickies in the room.
Two Vickies. Apologies. Sorry, Vicky, you go ahead.
So I think the purpose of introducing this is that obviously in QSP we have active discussions throughout the whole of the performance management report, but particularly this month we've had a workshop which was held 2 days ago, which I think was really helpful to board members. So we had exec colleagues there, we had non-exec colleagues in IMs, and actually what we saw very clearly was the benefit of the new divisional structure. If we're honest, it's not that long since that structure has been in place. But actually what the workshop demonstrated was the significant diagnostic work that the teams have been doing to understand the cancer pathways and to understand exactly what the issues were and develop the improvement plans. And furthermore to that, then the directorate structure that sits underneath that and the ownership at directorate level. So I think, I'll pass to Anne to take us through the particular highlights, but you will see in the QSP highlight report the areas that QSP particularly discussed. But I think what came out most fundamentally in that workshop and through the PMF report is the complexity of all of the cancer pathways, the amount of work that's been undertaken to make the improvements that are required, and therefore important, particularly from an IM point of view and our scrutiny at this board meeting and in our committee structures, understanding the improvement plans, the timescales that that's going to take, and as Jazz just mentioned, the transition over to the new Velindre Cancer Centre, and that's absolutely vital. So I think I'll pass to Anne now to take us through the particular highlights, but I would suggest that as a board, having similar workshops as we go towards NVCC is going to be really essential, that we all understand the nuances, the complexity, but equally, we did mention quite a few times the pace and drive and being very clear about timescales for delivery so that we can be clear as a board. So I'll hand over to you.
So I guess the thing to focus on is the fact that we've been on a journey. The first year or so we've been putting in place the infrastructure to enable us to do what we're doing and to do it well from a solid foundation. So the new structure, a data infrastructure so we can track our patients. The new structure and the teams that are in there have gotten into the detail. And we're focusing on those brilliant basics in this year and making sure that that foundation is completely solid, and we're building from that. So each one of the pathways has a new directorate team who have been in place since January and are focusing on the delivery of that pathway for our patients and the patient benefit at the other side of that. And as part of that, the transition to the new hospital and how that's, there's an improvement plan for radiotherapy. There's an improvement plan for SAT. We went through it in detail 2 days ago. To support all of that, we have a performance review approach with the new divisional team that has gone in monthly. So it allows us as an exec team to do the check and challenge on all of those plans. Acute is another big area for us, and we're changing our acute pathway. We're using the new hospital as a catalyst to do that. So there's a lot of work that the teams are delivering, but it will have a benefit to patients and outcomes, of which I'm really assured. And I think the next point on that pathway really is how we dovetail that with the plan to move into NVCC. So we've got our phase 1 plans are in place. Phase 2 plans is the dual running, and then phase 3 is the new clinical model and what we need to do in the future, working with the Federation of Specialist Hospitals and our OECI accreditation. I'm not going to go into the detail of the slides, but I'm open to questions on any of them. I'd like questions now, please.
Yes.
Can I just add I wrote some notes as we were in the workshop the other day, and I think some of the alignment with clinical pathways, clinics per se, and then the finance came out because there were 681 different codes.
That's struggling too, yeah.
And it shows the enormity of what's grown like topsy and needs to be defined through clear pathways so that we can align and make sure we're getting the income for the work that's being done across the organisation. So it shows the complexity.
Just as an example, those 600 odd clinic codes are going to be significantly reduced so that we have a set of clinic codes that are not as diverse as that.
Code cull, that's good. Vicky Oxley, it's your first meeting, so I'm not going to, but I know that this is a work in progress, and you'll be very much focused on what this looks like in the future. So you don't need to come in now, but if there is something you do want to add, then please do.
Thank you. It was just basically to say, because since I started, I've had a lot of feedback around the PMF and how we need to improve our processes around it. So just to assure the board that there is work underway, we are linking it with a paper that's later on around the assurance framework, to make sure we've got one version of the truth, that and so we all know what we're talking about. And the story is really clear, and I think that's really important that we know the story of what's happening in both of our divisions. We will be taking this forward over the summer through a task and finish group with the relevant people from across that workforce, finance, as well as the divisions as well.
Lovely, thank you very much. So on to specific issues and questions. We start with Lindsay and then Gareth, please.
Yes, thank you. And it was really helpful to have that workshop. It was really useful, a lot of information, and a lot of assurance that came through that.
Thank you.
I'm conscious as well that we're in a public meeting and people will not have had the opportunity to know all of that. We've got that information now, but not everybody will have had that chance. So I just wondered if it was possible to say a little bit more about the improvement plans that we learned about in detail. And I think there were a couple of the areas that have been pulled out in the report that it would be good for the board in this public session to hear a little bit more about. So an example would be the elective delay, and on the so this is 24 and 54, page 66 of the pack, where there is clearly a trend of not getting to the target, and that the decline that we've seen in that area. And there was one in again in the SACT, and just knowing that the action plans are there is really great. But I think kind of getting some assurance actually in this space.
Yeah, thank you for that opportunity. So the approach is very similar for both radiotherapy and SACT. We're looking across the whole pathway. We're modelling through each step in the pathway to ensure that we can deliver care to patients in the right time periods. Because at the moment, the way our services are structured sometimes, it doesn't give the team or the patients a sporting chance of having their care in time. So, for instance, in the SACT pathway, you can be seen in a new patient clinic. You have to have a pre-assessment clinic, but that does not allow you enough time as a patient to get your treatment in time. So we're redistributing those pre-SACT clinics across the week to increase access. And it's a similar story in radiotherapy. However, with radiotherapy, we know that our big win, if you like, is at the end of the IRS rollout program, because the functionality that will be provided by our new fleet will allow us to rapidly take time out of those pathways, and that will benefit patients. It will reduce the amount of time we need to spend planning, and will make us more responsive.
Thank you. Gareth?
Diolch Cadeirydd. Oes gyda ni amcangyfrif o'r canrif o'r wybodaeth yma dyn ni'n gasglu yn digidol, ac faint dyn ni'n gasglu llaw
Ar bapur.
ar bapur. Achos mae'r cwestiwn, mae yna lot fawr o wybodaeth fan hyn, ac mae'r cwestiwn hefyd yn ddilys ynglyn â'r set ddata graidd fyddwn ni'n sôn amdano nes ymlaen. Dyn ni'n mynd i gytuno gyda Llywodraeth Cymru. Felly, faint o waith sy'n mynd mewn i baratoi'r data yma?
Where are we with our digital data collection?
So the architecture in Wales for digital is limiting, if I'm brutally honest, and it was completely obvious at the UCLH visit. What we have done internally is we have created our own cancer PTL, which takes a feed from those multitude of host systems. That is not patient tracking list, sorry. It's in my
DNA.
So what the patient tracking list allows us to do is push patients through the pathway, see where delays are, and be able to offer patients treatment sooner. What I would like to get to is an opportunity where we have a shared PTL with our health board colleagues. We are working on giving them a view of our patient tracking list so that we can together work to get patients treatment sooner. So we've put in an internal solution. I think there's more opportunity working collaboratively, but I think we're going to be limited by systems that we have.
Gan faint o amser mae'r sefyllfa yna'n mynd i barhau?
Oh, Well,
I don't have a magic wall or a crystal ball. I'm sorry.
as it happens, Gareth, it's the DCHW conference today, where I'm sure these things will be, and it would be helpful. There are two things, and mae dy gwestiwn di'n un pwysig iawn, a mae'n ddau beth fan hyn. Gynta I gyd, mae eisiau ni fod saff, bod ni ddigon o ffocws ar dderion digidol yn y strwythur newydd, da ni'n rhoi at ei gilydd. Ac yn ail beth, dwi'n credu bod mi fyddwn ni angen diweddariad ar y prosiectau yma a beth sy'n mynd I fod yn digwydd yn genedlaethol. Mae hwnna'n rhannol ddibynnol ar yn partneriaeth beth sy'n digwydd yn genedlaethol, ond mae rhannol hefyd fyswn ni'n tybio'n ddibynnol ar be fydd blaenoriaethau y Llywodraeth newydd o fewn y cyd-destun sydd gynnon ni yn y gwasanaeth iechyd ar hyn o bryd. A felly, ti'n meddwl, mae'n bwysig bod ni'n cadw golwg arno fe. Ond am ateb, ti'n meddwl, cyfansawdd, wel, dwi'n arall yn dweud. Pwy a wyr, yn union.
And if I would add to that just very briefly, I think that then ties in with our risk register for both services, for both service, but also for the blood service. So I think, you know, that triangulation of information and clinical risk is something that we're very mindful of.
Those, is that an old hand, Lindsay? Yep. Jazz?
Yes, thank you. I just wanted to share that that we have initiated a conversation and a meeting with Ridian. So I've written to him on behalf of the organisation as medical director, flagging the clinical concerns, sharing our risk register, and an opportunity to try and work through some of this, because this conversation is inherently linked to us being an organisation of specialist services. We cannot deliver our ambition unless we have this architecture in place. And we understand we cannot do it now, but we need to have a plan that gets us there. So it's just to provide some context that these conversations are happening in parallel in probably a more systematic way for the blood service and the cancer service to have a clinical conversation about what this will for our patients and donors.
Yeah.
Thank you.
Thank you.
That conversation is scheduled for the 4th of July. Okay. Thank you.
So for the next board meeting then, should we capture an action around revisiting this?
Yeah, I think perhaps the holistic piece on which fits in with one of the actions that we've got already.
Yeah.
But we'll bring in the clinical component to it.
Yeah. That's really helpful. Thank you very much. Matt, is there anything you particularly want to highlight for us in finance?
Just give a brief summary of the discussion at the Quality Safety and Performance Committee, because I haven't reflected it in the apologies. So committee reviewed the March position for the end of the financial year. That agreed a strong level of assurance in terms of noting all statutory duties. However, there was a very lengthy discussion around emphasis on a forward-looking position and the risk around that, recognising the pressures in terms of ability to deliver current savings, workforce growth, and wider system funding uncertainties and difficult financial position of NHS Wales. So we discussed the importance of not over-relying on non-recurrent measures, the underlying cost pressures that we do have in the cancer service and Welsh Blood. We're having to fund those internally. Some challenges around commissioning and commissioning flows given the difficult financial landscape. So financial control and governance arrangements were considered robust and strong, but maintaining balance and the increased grip of control we're going to need the year we're in now is important, not least because of the transition into the new VCC and increased risk of all of that. The new accountability framework is important for us. You know, we're in level 1, so you know we're very much in self-control at the moment and light touch from any intervention, which is where it's important as a board that we maintain focus on staying
Yeah.
And that's it, really.
And we'll have an opportunity to discuss this in more depth this afternoon, because clearly this is an important strategic focus for us, and one of the key reasons why we have set up a performance and finance committee to very much focus on these areas. Is there anything in relation to this particular report? Vicky and then Lindsay.
I was just going to add to the last couple of conversations, because I think what emerged from the workshop particularly was the issue of understanding the totality of our risks, which we may or may not have got at a granular level in detail, but we understood that we needed to work through our revised committee structure.
Yes.
Current committee structure, but your reference to the new committee structure. But also in relation to what Matt's just been outlining, there was some discussion about the art of the possible in terms of new models of care, innovations, and some of the workforce issues that actually our current model within our full business case for NVCC doesn't enable, because there's a restriction in terms of the finance and the workforce models that went into that. Reference, and 7 days working, etc. So that there are some future pieces of work that need to be understood in much more detail, worked through the new committee structure, so that we can actually have a view of how we can support as a board the innovation that's
totally needed. I think that's spot on, Vicky. Lindsay?
I hadn't realised that we were moving on from the first part of performance management report, because that focused on the cancer services, and I wanted to raise something around it.
Of course, we'll go back. Apologies.
Yeah, but I just so I haven't got a point on that.
Okay. Do you want to go back and
if nobody else wants to come in on this point?
Yeah. No. Yeah. Go ahead.
Great. Thank you. Sorry. So I did just want to reference in terms of the blood service dashboards that we have, and on page 4254, which is and I know that there's a lot of work that has been done, and it is a really strong focus for the Welsh Blood Service about increasing inclusion across the whole blood donor panel. And I noticed through the information provided that we are gradually improving. We are getting there. We are getting increases in terms of diversity and inclusion on the donor panels, both for the whole blood donor panel and the stem cell register. What I didn't see in this, and I'm sure we have had it before, are the actions that are being taken.
Yeah.
So I'd just like to kind of flag that, either hear a little bit about that now, or make sure that we do get to see what the actions are to try and achieve our ambitious target, but you know, it's where we should be heading up to that 6.2%.
Can I make a suggestion that that's circulated, because actually there's some amazing things going on.
Yeah,
I mean, they are doing brilliant work on and the rate of increase of donors from particular ethnic minorities is just
it's gradual. I mean, there is a gradual, you know, from our chart we've got there, and I know the effort that's going into it. It's knowing what else is being planned so that we can still see that movement towards 6.2.
Definitely.
And Alan, director of Welsh Blood Service, and some colleagues went to visit NHSBT and their Brixton location, and saw some of the initiatives that they're taking there in order to interact with the local population, which is quite plural in terms of ethnicity. So there are actions that are going to be refreshed in that action plan as a result of that visit. I'm very happy to bring something through the next board meeting that would give us more detail on that in the same way that we have done with other improvement plans. And we have also put in place with Welsh Blood performance meetings, and donor recruitment and diversity is in there as something we want to, I think, give more profile to, because one of the big risks for the service, and we need to be more mindful of that.
Just to add that I had, after the Spotlight on Improvement session there on every day of the week, Friday last week, I had a conversation with Alan and with Sarah, they showed me the Welsh Wind Innovation Centre. And through that conversation about the opportunities that that creates for engaging with the community.
Yeah.
Increasing inclusion and diversity. So I know that they're on it. It's just good to see it reflected in the public papers as well.
Right, yeah. Gareth?
Cadeirydd, nôl i'r adroddiad ariannol os gai.
Yeah, wrth gwrs.
Mae'r sefyllfa ynglyn â'r cytundebau tymor hir yn ymddangos ym mhob adroddiad ariannol.
Ydy.
Ac o'n i eisiau gwybod, os ydy Llywodraeth Cymru yn ymwybodol faint o amser sy'n cael ei dreulio ar dreal cytuno y cytundeb yma. Achos yn ymddangos fi, mae eisiau rhywun roi pwysau ar felly'r byrddau iechyd.
Wel, os gai ateb hwnna, mae yna lot o ymwybyddiaeth o'r sefyllfa, a mae yna waith yn mynd rhagddi o ran y sefyllfa yn fwy eang, a dwi'n credu bod clod mawr i Matt a'r tîm bod nhw wedi llwyddo i gael ni fewn y sefyllfa lle dyn ni ddim wedi colli'r incwm yna leni, a bod ni wedi dod fewn ar ei ben, a byse hwnna byth wedi digwydd heb anferth a lot o waith gyda'r byrddau iechyd a hefyd y Llywodraeth. Felly dwi'n ffyddiog o hynny, ond mae yna gwestiwn chydig yn fwy datblygol i ni a strategol i ni, a gawn ni gyfle i drafod nes ymlaen, achos mae'n nawr, ond mae hefyd dros y blynyddoedd i ddod yn dydy. Diolch yn fawr. Okay. Let's move on then, if we're happy to the risk register and then the board assurance framework, and very many of the things we have just been talking about are on there again, which is as it should be, really. So, Non.
Hollol, diolch Gadeirydd. Ac yn y cyd-destun hwnnw, mae'r papur yma mwyn cynnig sicrwydd i'r bwrdd am y sefyllfa bresennol ar y gofrestr risgs. Mae'n adrodd yr holl risgiau ansawdd diogelwch sy'n sgorio 12 ac yn uwch, ac ar bob mater arall dros 15 ac yn uwch. Ers y cylchadrodd diwetha, ychwanegon ni 2 risg newydd, fel y gwelwch chi. Mae 2 wedi gostwng hefyd o dan y trothwyadrodd, ac mae esboniad o rhesymeg ar ostwng y risgau yna yn yr adroddiad hefyd. Mae themau allweddol sy'n codio draws y gofrestr yn parhau fod yn debyg i'r rhai rydyn ni wedi bod yn adrodd dros y misoedd diwetha, pwysig capacity, canlyniadau y gweithlu, yn un bwysig, difyniaethau digidol a technoleg wybodaeth hefyd yn ogystal ag ansawdd clinigol a rheoli a prosesau rheoli. Yn ogystal â hynna, mae'r adrodd yn cyfeirio at 2 ddiweddariad pellach yn wneud ar broses o reoli risg. Y cyntaf ynglyn â'r polisi risg sydd dal ac yn parhau i gael i adolygu, ond gyda'n cyfeillion bellach yn cydweithio yn line of sight, sydd yn rhannu ei harbenigedd ar hynny, ac hefyd ar y system newydd i ddelio â risg. Fe drafodwyd hynny yn y pwyllgor QSP ac yn y pwyllgor archwilio. Fe fyddwn ni yn adrodd yn llawn i'r pwyllgor archwilio nesaf, gan osod yr amserlen benodol ar gyfer hwnnw erbyn mis Tachwedd 2027. Y cyfamser mae cyfeillion o gwmpas y bwrdd yn hapus drwy'n siŵr i adrodd ar unrhyw gynnwys sydd yn perthyn i'r risgiau sydd yn y gofrestr.
Oes na unrhyw sylw ar y risgiau myfynnol i ni? Oes, Lindsay?
Raise my hand.
Wedyn Hilary.
Yes, I mean, I do think we're getting more mature in the way that we're dealing with risks, and it's really welcome. So I think the engagement, certainly we're getting that engagement and being able to have some conversations that focus in on the risk areas. I think there are still a few practicalities which it would help us to do that even better. So I noticed in looking through today's risk register that a number of the target dates for our achieving our target risks are kind of like next week or very soon. And there are examples where the mitigations in the update column would indicate that we're not going to achieve that, but the deadline hasn't been changed. And there are others where it's not clear. So it looks ambitious to say that we might be able to achieve that target rating. Now, that's part of the tool, is to enable us to know where to focus. So if it looks like we're on target to achieve our target rating, that's within risk appetite, that feels as though we have good control over that risk. Where we're right up against the deadline and we seem to still be a long way away from achieving that target, that is our concern. And there are a number like that in the risk register this time. So it means I'm not quite sure where I need to focus my attention in terms of getting assurance around those risks. Then having the target dates clarified. Not saying we have to do all of them in this meeting, it's a point for future, but it really does need that engagement. Otherwise, as I am, and particularly, but other execs who aren't close to each individual risk, don't really know what we're being asked to consider.
I mean, I think that's a very good point, Lindsay, and obviously it is for the executive lead for that risk to take, personal interest and responsibility in actively reviewing those risks and providing that realistic assessment. And it links obviously to the divisional board meetings and the committee meetings and so on. So yes, thank you, Lindsay. Hilary.
Diolch Cadeirydd. Mae Lindsay wedi dweud rhan o'r pethau o'n i angen dweud, ond yn benodol ynglyn â risg 3216, gan bod hwn yn bapur sy'n cael ei gyhoeddi i'r cyhoedd, does dim actions yn yr action log column na due date, so falle gallu rhywun edrych ar hwnna, achos fi'n gwybod nilon ni drafod yn yr workshop dydd Mawrth, ond fi'n credu dylen ni lles y cyhoedd rhoi rhywbeth mewn fyna. Wedyn ni, jyst yn gyffredinol falle, ond mae'r risg 3677 yn dod ag mwy yr amlwg na dim yn man arall. Mae'r geirfa sy'n cael ei ddefnyddio yn gweud rhywbeth fel escalated to call yesterday, we're meeting tomorrow. Dyw na ddim yn golygu dim byd i'r cyhoedd, achos dyn ni ddim yn gwybod pryd mae fe wedi cael ei ysgrifennu. So just i bawb sy'n ysgrifennu yn y columnau, mae bod nhw yn ystyried na. Diolch.
Ffaith iawn. Siarad efo ni'n hynna'n digon teg. Diolch yn fawr. Fe nawn ni nodi y ddau beth yna.
Absolutely. Gai just ddod nôl a dweud, dwi'n meddwl bod chi wedi clywed ein pwyllgorau ni ar sawl cyfri yn crybwyll yr angen am smart actions o gwmpas risgiau, a hefyd dwi wedi sôn ynglyn â phwysigrwydd cael targedau realistig ar gyfer gweithredu y risgiau yma. Mae'n amlwg bod angen wneud llawer o waith hyfforddi o fewn y sefydliad i sicrhau bod pobl yn deall beth ni'n feddwl pan ni'n dweud y pethau hyn. Mae yna ganllawiau wrth gwrs, ac mae hynna'r gael, ac mae'r risgiau yma'n mynd trwy amryw ffyrmau ar ei ffordd fyny yma, ond mae'n rhaid i ni nawr rhoi cynllun lle sydd yn cynorthwyo'n staff ar y llawr i sicrhau bod nhw'n defnyddio'r system fel y gydyle hi fod yn cael ei defnyddio. Fyddai'n edrych i gydweithio gyda cyfarwyddwyr i sicrhau bod hynna'n digwydd.
Wel, dwi'n credu bod hwnna'n ddigon teg, ond hefyd fel y risgiau ddim bod fan hyn, heb bod y bobl sy'n berchen y risgiau yna wedi edrych drostyn nhw ac perchnogi nhw. A mae gennym ni lot o dalent rwy'n dy bwrdd fan hyn. A gallwn ni ddefnyddio hwnna hefyd i helpu nhw fentor a datblygu y bobl sydd yn falle'n poblogi rhain. Ac unwaith mae hwnna wedi wneud, dwi ddim yn credu bod neb rwy'n dy bwrdd na ddim yn gwybod sut mae cofnodi risg mewn ffordd smart, dwi'n gwybod beth yw'n Gymraeg. Smart. Ond felly, ti'n gwybod, a mae'n help yn dydi, still awr gyda'r staff chi a trafod dyma beth sy'n angen, Mae'n sort of teach a man to fish kind of thing, ti'n meddwl? Ydy hyn, really. Wenglish. Hello, John.
I can't use the electronic
Yeah.
system. See, it's sort of said, but and I don't mean to state the obvious. These are our top risks as well.
Yeah.
Yeah.
You know, these are the most important risks for the both health and safety, 12 plus, 15 and above. So I wonder all the other. I don't know how many risks on the total risk register, but it'd be interesting to see if we looked at all those as well. It's quite a lot of work, I guess, for people to do to bring them up to date and to check the smart.
Okay. I totally agree. We won't prolong the discussion. There's an action there. All risk owners, nurture and love your risks and make sure that they come here in a way that really kind of supports scrutiny and assurance. Thank you very much. Which takes us on to the board. So we'll be happy to note, yes, with the and then let's move on to the board assurance framework.
Diolch yn fawr. Na i gadw hyn yn gryno iawn. Diolch i bawb am yr input ar gyfer risgiau newydd. Mae'r BAF yma'n cyflwyno y risgiau strategol a gytuno fel rhan o'r IMTP. Y tro hwn, rydyn ni wedi cymryd mantais o'r cyfle hefyd i ddiwygio rhywfaint ar y template sydd gobeithio yn plesio. Gawson ni drafodaethau da yn QSP ag yn y pwyllgor archwilio hefyd ynglyn â sut i wella ymhellach y cynnwys sydd yn y BAF ac o ganlyniad fe welwch chi bod ni wedi cynnwys sgoriau bellach o fewn y template ar gyfer gallu, dwi'n dweud hynna, a da ni wrthi yn gwneud hynna ar gyfer y risgiau sydd wedi newid rhywfaint ers llynedd ond ddim wedi newid i ni cyfanrwydd. Mae hwnna yn rhywbeth fyddwn ni yn sicrhau sydd mewn lle ar gyfer tro nesaf hefyd. Fe wnaeth cydweithwyr ateb cwestiynau ar gynnwys y risgiau strategol penodol os oes gennych chi fel bwrdd o'r fath.
So again, we're asked to note the BAF. Vicky.
I think just to comment, because it would be remiss of me if I didn't, because I think the point that I've been making over a long period of time is the alignment to strategic objectives. The work that's been undertaken, and I don't underestimate it, is really welcome because this is the first time that we've seen that alignment. I guess the question from that is actually for the IMTP and the strategic objectives, is this the objectives that are set for this specific year? For the 3 years, is it this current year or 3-year period?
They're mainly based on the strategies that we have in place currently. So they are aligned, so the IMTP aligns the strategic objectives in those strategies within the IMTP. So there is a follow through.
It's a hierarchy.
Yeah, so it's mapped across, I understood that, but actually is it based on what's in that IMTP for this current year, 26-27, or is it for the 3-year period? And it's being clear about that because as a board, we need to be very clear about the deliverables for this current year demonstrated through the BAF. That was my point. Sorry, not okay.
But we can clear that up.
Yeah.
Yeah, let's clear that up.
So, and I think just if I can come back with the second point, because I think, again, the attention to detail by all executives on the board within the BAF. And we had some discussion on this in QSE. So this discussion has been had there, which was very much about the gaps in controls, the gaps in assurances that are demonstrated through the BAF. When you look at the narrative and not actually gaps, they're actually trying to be positive assurances, and that misses the point. So I think I would seek exec colleague support in making sure that the next time that we see this at the board and through our committee structures, that actually that due attention to detail has been paid and that is there, because that's the support that we need as a board to be clear, because we will need to focus on the detail of those gaps. And
yes,
that's the purpose of the discussion.
Yes, thank you, Vicky. Lindsay.
Just wanted to pick up on a point that's in the cover paper about part of the conversation we had at QSP, which identified the need to just look again at BAF 6 around people on OD and to get a bit of clarity there. And a quick chat with Seb share it this morning, and it's something that I'm really happy to have a conversation around. I mean, clearly that, you know, articulating that and bringing it back to us will be to please everybody. I will have a conversation with Sarah.
Yeah. Thank you very much. Anyone else?
Law I lan.
Oh, Gareth.
Diolch. Just a pwynt dwi'n wneud yn gyson ni'n trafod y bath yw fod y sgoriau ar y risgau yma wedi bod yn gyson ers amser maith ag, wel, blwyddyn falle. Mae'r wybodaeth gyda ni am blwyddyn, ag fysau yn neis gweld rhai o'r sgoriau yma yn gostwng. Oherwydd mae'n awgrymu i fi bod y camau lliniaru ni wedi rhoi yn erbyn rhai o'r risgau yma. Unau ddim yn gweithio, neu ddim yn cael ei gyflawni. Ag hefyd mae rhai o'r risgau unigol sydd o dan rhai o'r uwch risgau yma yn uchel ofnadw yn 20 ag mae eisiau gweld rhywun ni'n dod lawr hefyd.
Ie, bwysig. Ie, diolch Gareth. Rhywun arall? No, dwi'n mynd i methu neb na. Okay, colleagues, we're going to take a short break now. I suggest we just take 10 minutes. And we are running behind because we started late. And so I'm also going to propose that we truncate our lunch break to catch up with ourselves. But please do go and stretch your legs and come back at 12:14.
Precisely.
Precisely.
That's new.
In there.
Be able to speak if you can.
Yeah. Let's do. We'll
Thank you. Welcome back, everybody. We're now moving into the organisational development part of this agenda. And our first item is really important for the future, large for all of us over the next few years. So I'm going to hand over to Vicky Oxley to take us through the new operating and accountability arrangements. Yes, Jazz.
So just before Vicky comes in and gives us the context of what it means for us, I think just a little bit around where this has come from. Many of us will be familiar with the MAG report, the Ministerial Advisory Group, which set out a number of recommendations. I think there were a number of pieces of work that have been going on in the background, which have led to the overall kind of position that change is needed, something around modernizing our kind of processes and the way we are set up, simplifying things, strengthening the accountability and the operating model. And this is where this has come from. So, you know, the aim of it all, I guess, is to drive change, to ensure we're measuring the right things, to have more focused, fewer priorities, and also create greater transparency, which are all themes that, in fact, we have been talking about as a board. And so there is an opportunity, I think, here for us to align this to the work that we're trying to do anyway. But over to Vicky, thank you.
Gareth's got his hand up. Is that an old hand? Oh, okay, there we are. Old hand. Okay. Vicky.
Okay, sorry, thank you. So I'll take paper as read, but the things that I wanted to point out really was this is now live. So this is actually our arrangements that are in place. And I have, and I think one of the things that we've got to be really clear of is that this is something that we, you know, it is a Welsh Government framework, but it's something that we need to make sure it works for us. And so earlier on, when we were talking about the performance management framework and having one version of the truth, that's where it links into this piece of work. So as you'll have seen in the appendix, there is an expectation that we will produce a data pack, or we will be part of a data pack. Welsh Government are talking about pulling information into a dashboard. And so what we need to make sure is that that information is relevant to us as a trust. Because one of the key things is that we are very different to health boards, and what we got to make sure we are not done is monitored on what health board is monitored on, because that is very, very different for us. So I had a meeting yesterday with Welsh Government to start that conversation around making sure that the data pack is relevant. We will be expecting shortly, I believe, an invitation from Welsh Government to, I'm not sure if it's the exec and board or just the executives, around starting to have a baselining conversation around how we are doing and what we are doing. So that will be imminently. I've been told it'll be happening at some point in Q1. So we'll be needing to get ready for that. Yeah, Q1. It wasn't supposed to be, and I think it's been brought forward. We want to have conversations with all organisations in Q1. But that is really, I think that's very much sort of a baselining conversation. But I think what we need to be really clear is, what's important to us is that we're being measured on what matters to us and not what matters to health boards. Some of that will go across. So a lot of the workforce measures obviously will be the same. A lot of the finance things will be the same. But from a quality and safety perspective and a performance perspective, it's going to be feel very different for us. And I think we've got to really proactively shape that. Obviously, it is tied to the escalation process. So there are potential, ramifications of not partaking within this. At the moment, we are with the lowest level of escalation, and as long as we continue to do that, it should be relatively light touch. But obviously, if that changes, then this framework will kick in regards to how we are performance managed from a Welsh Government and P&I perspective. So I think those are the key things that I wanted to point out today. If there's any questions on the content, I'm happy to answer any. But it's live now, and we need to work with performance and improvement to make sure that it's relevant to us as an organisation.
That's a really helpful introduction. We will all have read the paper, so we're asked to note and then discuss this. So we'll go to Anne first, please.
Yeah, I would just I think it's a good opportunity because we're looking at how we do things really differently. And there are some key, I guess, performance indicators that we've established internally that I think we should be sharing with Welsh Government, because I think they could be quite pivotal for supporting the delivery of the cancer pathway. And I think it would really help Welsh Government understand the contribution that WBS has as well, if we can describe those. And I guess the pillars map onto our board structure going forward as well, so that is helpful.
And in some ways, you know, the way that we are structuring our committees and our focus is prescient, and as you say, Daz, builds on what was in the MAG, and we need to align it with these pillars. Gareth.
Diolch. Oes gennym ni unrhyw dystiolaeth, unrhyw wybodaeth eto ynglyn â'r dystiolaeth sy'n rhaid i ni I baratoi ar gyfer y parth arweinyddiaeth?
Mae'n datblygu dwi'n credu. Dyn ni wedi cael cynllawiau ynglyn â amcanion, sut dyn ni'n delio gyda amcanion, ac yn neud yn siŵr bod rheini'n treiddio drwy'r corff, a bod y dystiolaeth ynglyn ag cyrraedd amcanion yn dod nôl lan, ac mae'r amcanion hynny yn bwysig bod nhw hefyd yn glynu at y strategaeth, dyn ni'n gwybod hynny. Dwi'n credu bod yr pilar yma yn rhywbeth lle fydd na lot mwy o waith yn cael ei wneud gen y Llywodraeth Newydd dros y misoedd nesa yma. Dyn ni yn amlwg yn barod wedi bod mewn I Public Accountability Meeting, a fe fyddwn ni eto'n fynyddiol, so mae hwn yn mynd I fod yn gweithio drwy'r flwyddyn, ond wedyn gorffen lan gyda'r cyfarfodydd cyhoeddus yna, lle dyn ni'n mynd I orfod bod yn atebol I bob un o'r pileri yma. Felly, mae gynnon ni rhai o'r rhain, Gareth, ti'n bod o ran mesura ac yn y blaen, ond be fyddwn ni'n disgwyl, y bydd na fwy yn cael ei ddatblygu ar hyn, achos falle bod y bobl eraill yn y stafell sy'n gwybod mwy am hyn na fi, ond dwi'n credu bod e'n tynnu ar be maen nhw wedi bod yn gwneud yn Lloegr hefyd. Jill,
Yeah, I think one of the things that's coming out of some of the discussions that are already happening around this are around the measures, and I think around productivity, for example, and efficiency. I mean, I know this from a medical director perspective because we've been asked by the CMO to write a paper on what it means. And I think there's going to be much more of that sort of focus, which will mean us gearing up for it. Absolutely. Where's our data? How do we report that? How do we scrutinize? And that is a shift where we've been. So I think that's one of the examples that I can give, a live example of what is starting to happen.
Yeah.
Can I just add one thing, just that I probably should have said, is that as it sets out in here, there is an expectation that we will be utilising the data that Welsh Government are using as part of our own board and committee structures. And so this is where, I guess, just to re-emphasise the point around the performance management framework, and this needs to be the same thing. And a lot of it, like Anne said, aligns really naturally to our new committee structure, which is fantastic. But we've got to make sure that we're talking to the same thing, because it's really clear in here that we have to take these through boards and committees, this information.
Yes, Lindsay.
Well, that was exactly the point, as you can imagine, was going to come in on, which is, and we did have some of this conversation at SDC around the importance of mapping all of this into the committee structure, and actually the main pillars and the well-led as a foundational piece really well across. So I think we are already kind of getting geared up to be able to receive this quite well. But I absolutely take the point about it. We need to be measuring the things that are important to us, as well as what is already going to be embedded and required by Welsh Government. We need to be very clear on that side as well.
Sorry, me again. In terms of the pillars and well-led, I mean, it's very similar to the CQC pillars and well-led process. So there's lots of benchmarking we can do and learning from others. And you know, the more links we can do to help us with that, the better. And I think the OECI is the other thing for us that's really important, that supports that more global look and how we can improve outcomes. Because, you know, we are in a very challenged place for outcome for cancer patients, and we need to be mindful of that. That's the goal, isn't it?
Okay, so we're asked to note, but we're also asked to discuss, and I guess for me it's the so what, because this is absolutely so important for us. So we know, Vicky, that you and the rest of the executive are going to now to make sure that this works for us as a specialist organisation. And we're going to be aligning with our committees and with a review of the way that we are performance reporting. But I think this is also important that we bring this back to the board and board development on a regular basis, and that this is an introduction really, so we can see what's in here. But the so what is really, really important, and it emphasizes as well, if we're going to get this absolutely right, the need for prioritization. So it may have knock-on effects on some of the things that we maybe don't or decide not to do. And you know, as we go through the agenda today, what we're trying to do is streamline what we do so that we land and do things well, rather than trying to do a million things and go off in a million different directions. And in some ways, this is a very helpful sort of anchor document. It doesn't include anything for us, not at all, but it is our license to operate, if you like. So, Jill.
I think it's important to know this is a change for us, and it's come at a really good time as we are reviewing and looking at our systems and processes internally. It's also a massive change for Welsh Government. So this is an opportune time to work with them and make it right for us, because they, you know, it's all new from our side as well, with the new new ministers and cabinet secretaries as well. So I think we do have an opportunity to make this work for us.
And that was clearly going to be a focus for all of you ahead of the next time you bring this back to us. Yes. Thank you very much. Ben, welcome. I'm so sorry that we've had technical and IT issues, but I'm really pleased to see you. Thank you for joining us.
Thanks for having me.
Right, should we go on very neatly onto the review of the board committee structure and an update on that from Norm, please?
Diolch, mae'r papur yn gryno iawn, a prif bwrpas y papur yw cynnig i chi newid mewn amserlen ar gyfer gweithredu yr strwythur ar gyfer y pwyllgorau, yn hytrach na ddechrau fis nesaf. Rydyn nawr yn sôn am gytuno y ffordd ymlaen ar yr 10 ar 20 o fis Gorffennaf a gweithredu y strwythur newydd o hynny ymlaen. Hoffwn i ddiolch i bawb sydd wedi cymryd rhan mor gyflawn yn y broses hyd yma. Mae'r sgyrsiau gyda line of sight a'r gylchgorchwyl y pwyllgorau wedi mynd rhagddyn nhw yn hynod o effeithiol. Mae wedi bod yn sgyrsiau difyr, ond hefyd darllenol o ran yr hyn sydd angen gwella arnym ni. Bydd y gwaith hynny yn parhau dros y misoedd nesaf cyn cyfarfod nesaf y bwrdd, ond am nawr prif bwrpas y papur yw cytuno'r amserlen newydd.
Lindsay, do you want to come in on this, or?
Yeah, if I just add a little bit to that. I think it's been really helpful that as part of this process, I've been able to engage in a conversation with each of the IMs who are meeting up with their exec leads and line of sight. So being able to get a kind of an overview of some of the issues, and I'm really, and Carl's very happy if I have conversations with exec leads as well. Really welcome that, just to get that complete picture. And I think there's a number of issues bubbling up for each committee to kind of work through, and that's all the point of conversation, and giving us enough time so that that's really important. with something perfect when we start, but with something that's good enough and that we know we can refine and review. But I'd say one of the main things that everybody's saying as well is that it's going to be very important to have that opportunity to kind of check that we're not letting anything fall between the new, the committees and the new arrangements, and also not duplicating and doubling up. And I've heard that a number of times. I think we'll also look at how we might need to take things to different places, but for very different reasons. So some of the deep dive scrutiny may happen in one place, but then some of the higher level oversight assurance would be happening somewhere else. So that we make sure that even if we're disaggregating things to the committees, we still retain, and that might become the remit of part of the audit and risk assurance committee, but we retain that assurance oversight on certainly on how our governance is working.
Yeah.
So it really good conversations happening, which is great, and that's what we expect to see in this one.
Well, I want to thank IAMS as well for their very active involvement and working with their executive partners and leads to develop this. I mean, it's bringing a lot of things to the fore. It's a very rich discussion, yeah, I think it's really helpful. Okay, anybody else on this? No? Okay, and we have a date on the 11th of June with those people that we're working with to get together to review everything that they found so far and to come out of that with a board development plan and also with this revised governance plan ahead of us going live and getting it right. It's our deadline, so we need to. So it's better to get it right, although it will then refine. Okay, thank you very much. And that takes us neatly on to Sarah and the streamlined approach to the cultural milestone plan.
Thank you, Chair. I'm going to take the paper as read and just want to introduce it briefly to highlight some key matters. So in March, we recognised the 3-year culture milestone plan. It's important strategic framework for strengthening our organisational culture across the Trust. Since then, we've moved into the implementation planning, and we've undertaken further work across teams to understand sequencing, interdependencies, and organisational delivery capacity, along with the significant strategic and operational priorities currently underway across the whole of the organisation. At the same time, our recent staff survey results outcomes provided encouraging assurance that we continue to maintain a strong cultural foundation across many of our key areas. Taken together, this has created an opportunity for us to refine the implementation approach for the plan, not to change its ambition, importantly, or direction, but to ensure the way that we deliver it is proportionate, integrated, and is sustainable. So the proposal before the board therefore focuses on streamlining, effective triangulation, and embedding that culture actively more directly within operational delivery and transformation programmes. That will help reduce duplication and concentrate an effort on the cultural enablers that will have the greatest impact on workforce experience, leadership, and strategic at the same time. We recognise there's much going on across the organisation, and what we want to do is ensure we enable all teams to succeed in this space and the board together with them. So importantly, this is an evolution in implementation rather than a change in our strategic intent. Our values, commitments, and overall cultural ambition remain unchanged. But we believe this approach will support greater coherence across the organisation. It will reduce initiative burden and help ensure culture continues to operate as an enabler at the heart and delivery rather than a standalone programme of activity. So we are seeking a board approval today for the proposed refinement to the implementation approach as set out within the paper and the key focus areas that are detailed within it. Happy to take any questions.
Thanks, Sarah. Just a point of clarification. So page 4 of 7, there's a 0.5, but then there's a gap. Is there something supposed to be there, or is that just a typo?
Apologies, it's a typo. There are 6 key areas.
There are 6. Thank you.
Well spotted.
I wonder what. Fine, that's fine.
Thank you. Anne.
Thank you, Chair. So it was on reflection reading the paper. So thank you, Sarah. It was on reflection reading the paper. I know we're trying to bring it together in a place, but I think there's an opportunity for us also part of this to bake in being a learning organisation into this, because we talk about being a specialist, an organisation of specialist services. The important leadership role there is that we have this way of agilely working that brings in our D&I, and we are continuous learning, continuous improving organisation. And that's really critical. So getting that explicitly somewhere, I'm sure it's in there somewhere, but just to be explicit about it. Thank you.
Yes.
Number 5, is it?
Yeah. Gareth.
Diolch. Ar yr un dudalen 4 o 7, mae yna gyfeiriad bod na ystyriaeth cenedlaethol ynglyn â'r datblygiad arweinyddiaeth. Ydyn ni yn ofni bod hwnna mynd i oedi y gwaith dyn ni yn bwriadu cyflawni o fewn Felindre?
I fi, na, dy ddim. Mi oedd na llawer iawn mwy o waith. Dwi wedi bod yn gweithio gwmpas Llywodraeth a bydders amser maith. A mi oedd na llawer iawn yn fwy ar gael i ddatblygu arweinyddiaeth ar draws cyrff cyhoeddus. A dros y blynyddoedd mae hynny wedi cael ei wanhau. A i fynd yn ôl at yr eitem flaenorol, y well-led domain yna, fel cadeirydd, fel grŵp o goduryddion, be dyn ni'n disgwyl gweld ydy cryfhau sydd ar gael i ddatblygu pobl fel arweinyddion. Ond falle bod gen Sarah chydig fwy ar hwnna o'r ochr fwy arbenigol hynny ydy.
So it's about building foundations at different levels in terms of leadership. So fully support what the chair has acknowledged there. There's a lot of work going on. One of our aims here is about ensuring, actually, picking up on Anna's point, we focus on the right leadership behaviours we need within Velindre in order to achieve our strategic ambitions. And that's actually where our behaviour framework becomes really key. That would be one of the first actions that we will look to work with everybody embedding. It sets the tone then in terms of, and we will have to cross-reference this with the work with line of sight, because obviously leadership starts with the board. So a need to ensure key behaviours and attributes of our leaders across the organisation in order to help those behaviours help us deliver that strategic ambition. For me, this is about encompassing all of the work in one even space. The board has a thirst and an appetite to have action plans, rightly so, to see impact. One of the things I am doing at present is looking at merging 7 of our action plans that all connect to this in some different way, in a much more streamlined way, so that actually we focus on doing the right things to have the right impact, and where less is more in terms of that issue, and that you have oversight in terms of what that means.
Thank you. Else, so are we content to approve the proposed refinement? Yes. And then to improve the focus on our governance and leadership work, executive team recruitment, supporting a Velindre Cancer Service to move, building on actions already taken, such as speaking up safely and embedding these in assessment, things that we have already done, staff survey engagement and action planning, and wider leadership development that is going on, more widely within the NHS. Approved. Thank you very much. So that takes us on to committee highlights for discussion, and we have the Public Quality Safety and Performance Committee highlight report, which we're asked to discuss and note the key deliberations and highlights. Who's going to take us into this, Vicky?
Yeah. I think if I just start this off, and then I'm going to pass to Non to pick up particular issues. But I think the purpose for it to come in for discussion is around the trust risk register. So we've had discussion, haven't we, in the previous papers. Won't take us through that again. But part of the QSP discussion was based on the looking at an enhanced risk management system that we're looking to procure. So currently we're on the DATEX system. My understanding as chair of QSP wasn't as clear as perhaps it could have been, but I'll own that as well, in terms of being clear about what the board was cited on the process, because there was a lot of work when we updated from an old DATEX system to the new DATEX system about a year in after I commenced. And I think then that the training and the lag in terms of where people are at across the organisation, so at directorate, divisional level, there was quite a lot of delay in people getting up to speed with that and being able to implement it. And therein, there are some risks for us that we need to be cited on as a board. So I wanted us to be clear as a board about the process that we're going through in terms of looking at that procurement, and Non's who obviously is very clear on that, but I just wanted us to be aware of it and then to be able to track it through.
Yes, so there will be, as I mentioned, a very detailed piece coming to Audit Committee in September to outline the plan and where we are on its implementation, actually in the lead up to that procurement exercise. We discussed it, or one of the questions you asked at QSP was whether or not there would be a Once for Wales solution around the risk management system. Again, and the answer to that is no. Lauren will have significant experience of the last attempt to deliver a Once for Wales risk solution, or the update to the All Wales solution. There is no appetite amongst colleagues, and everybody's at a slightly different stage of maturity in terms of systems. So many have gone to new systems already. What we are doing is working with those who are currently on DATEX to understand requirements, to learn from each other. As you saw from the risk paper, we've also already undertaken one demonstration day where we had, I think, 5 suppliers come and talk to us about the systems there, and we're sharing that out with a wider group in NHS Wales. So the answer to the question whether or not we are going back to a similar formula for procuring a system is no, we are not currently. But I think the detailed paper will come to audit in the new year. In the new school year. You tell that I'm GCSE focused at the moment. Yes, you can. In September. So that we'll have up to about 12 months. And just to reassure as well on that, many of our colleagues working in divisions and in support services are involved in that registration process. So it's great to have cross-organisational attendance at that first at that first day, because there is a keen interest in it, for various reasons. Yes.
Yeah, thank you. Okay, Lauren, and then Gareth.
Yeah, thank you, and can talk more about the history of the procurement if it's helpful. I suppose I'm just going to also make the point for assurance purposes, but in terms of comparing apples with apples, because when we first did the implementation of DATEX, yes, it was one system to another. That was going from a very limited, there were 20, 30 people who had access to the original DATEX system, and most risk registered Excel and Word documents and all goodness knows what else. And so it was a complete shift at that point to everyone in the organisation having access, everyone being trained in terms of their responsibilities, the level management then in terms of the review of those risks. So it was it was a complete thing of which the system itself was a part. So I think it's compartmentalising and what the change would be to get it into a system that everyone would recognise as a type of system that we would be used to working. I think it demonstrates quite how clunky it is. Maybe take that offline.
And I think just to add to that, some systems have the functionality, they have the ability to enable us to include the BAF on the same system as well. So, you know, there are significant steps forward that we can take based on what we already understand as the art of the possible.
Yeah, brilliant. Thank you.
Gareth?
Mae'r adroddiad ymlygu yma yn llawer mwy cynhwysfawr, fi'n credu, ac dwi'n derbyn bod hynny yn dibynnu raddau ar y pwyntiau sy'n cael eu codi, ac hefyd ar waith line of sight. Ond jyst eisiau ni fod yn glir ynglyn â beth yw'r disgwyliad ynglyn ag adroddiadau amlygu. Mae hwn yn hyrach na'r arfer, mwy o wybodaeth ynddo fe, ac os mae dyna beth ni fod i wneud yn y dyfodol.
Ni'n deud na.
Mae hwn yn sgwrs fyw iawn ar hyn o bryd, so mae hwn yn un o'r pethau byddwn ni'n disgwyl bod line of sight yn trafod gyda ni ar yr unfed ar ddeg o Fehefin pan fyddwn ni yn. So mae'r holl broses o adrodd a, dwi'n cofio beth yw'r gair am esgleitio yn Gymraeg.
Sgyn.
Diolch. I'r bwrdd yn fater da ni wedi bod yn gyda line of sight ag mewn amryw o'r cyfarfod wedi cael gyda caderyddion. Beth sydd yn addas, beth sy'n priodol, beth sydd yn gallu'r bwrdd i wybod ble mae'r risgiau mawr.
Ydyn ni'n hapus i nodi? No? Oh, Anne, mae'n ddrwg gen i.
So I don't expect an answer to this at the moment. I just would like to put it on the table. If there are any risk systems that are integrated with any of the other systems that we're likely to be using, such as the acuity tool in VCS, etc., it would be a benefit to look at those rather than a standalone system. I think where possible we should have that lens on things. So I'm just putting it out there as it might be wanting my cake and eating it, but you know, if it was available, it would be good to see.
Yeah. Want to come in there, Jazz?
No, I think just supporting what Anne is saying, this is the opportunity to have a look at not just what's out there, but how we use it and how it aligns, because we don't want to have to do this again. And I think let's get it right, but we're evolving, so it needs to kind of be right for now and the future.
Anyone else? Jill?
Just to have on record, and we've had this conversation to ensure that we've got our national, so Digital Healthcare Wales or any digital government colleagues involved help with the with our existing programs. And to note, it's a disappointment that we're not looking at an all Wales solution around this.
The list for DHCW is getting longer through this meeting, but yes.
Yes. Matt?
Yeah, just build on that point. So obviously procurement, when you're designing the procurement, have the interface capability, and a lot of the standard Microsoft products will have that, but you just need to make sure, liaising with Digital Healthcare Wales, have got that as a requirement.
Yeah.
And that may limit your pool, but they shouldn't do these days. All these systems should interface and be able to.
Yeah. Okay, I can't see any more hands up. So are we?
I don't.
Sorry, Anne.
Trans, so I don't know whether you want. It's on the report,
in the report.
And it's been subject to much discussion in the past. But just the report here suggests delays, delays maybe to full business case, delays in recruitment. Belinda, of course, has some specific requirements as previously discussed, and needs continued oversight. Are there further delays beyond what we were proposing in terms of the full business case? So it's just useful to know, given the timing,
quite right.
The new centre and so on. It'd be very useful just to give an update.
Yeah, happy to do that. And this is based on the last trans programme board, which was nearly a month ago. So in essence, the original plan that we were all working to was the Southeast Hub was going to be available, becoming operational in April 27. That was dependent on getting from OBC to FBC, and getting the FBC into Welsh Government before the end of March for approval by the then Cabinet Secretary. For various reasons, that didn't happen. So there has been a built-in delay. Consequently, we understand that, and Welsh Government have confirmed this, that the earliest we can expect the South East Hub to come online is March 28. And it's a continued question I ask at every programme board. There are still some outstanding issues that we need to resolve in terms of making sure that the asks for Velindre are taken into consideration in terms of that FBC. We haven't got the final FBC. We're due to have it, I think it's later this month, the beginning of next month. So we'll have to see how those come out. But Matt's team have been involved in that discussion and are waiting to scrutinise what's shared with them. The impact in terms of the South East Hub, it does mean that we will have to manage our own risk locally, and we won't have the backup position of having an operational South East Hub when we move into NVCC. What good looks like in terms of commissioning a unit, and you probably know much more about this than I do, I'm an interested amateur at this stage, is 6 months. So we're trying to allow a year in the programme to ensure that we have contingency.
Very important point you've raised there, Andy. So for those of you who are joining us, TRAMS is Transforming Access to Medicines.
It is well remembered.
Yes, it's in there. This board has previously taken a decision to retain some of the functions that are crucial to our sustainability of treatment, and that was obviously, you know, the right thing to do. Yeah. Nevertheless, it leaves a risk in terms of the remainder, and Andy quite rightly pulls that out, and perhaps some thought as to how that remains under scrutiny in terms of the implications for us and our patients. Vicky.
I think just on that point, I think it's really important because it comes through from the medical director of I was going to say shared services to the committee. I met with him on an individual basis yesterday just to go through some of the issues that come through the committee, but we also talked about our representation in the shared services committee itself, and actually how we triangulate the information and escalation of concern in that forum through to ourselves, both at board and committee level. So I accepted that there's a real ownership that we need to take to make sure we are completely on it, Andy, as you were saying, and we understand it not just being reported through to the Quality and Safety Committee.
I mean, sounds like there's a key risk that has now shifted firmly into our camp on opening the new cancer centre, that we have to take care of ourselves in a way, because we're not going to have a South East Hub operational for at least
an extra year
or something. Yeah. Okay.
I get, in terms of the risk, it means that business continuity isn't available to us. So we would have been able to flex a little bit more if we'd had that.
Is it on this particular point?
Yeah. I mean, I think we need to bring something back to the board to an assessment of what the current position means for us and the mitigations that we will put in place to address any increased risk as a result of the dates that are being discussed here. I would suggest that Carl, myself, and Anne take that action. There are a number of threads to this, and I think we haven't refreshed at the board what the position means now. I would suggest we do that, because otherwise we could discuss this.
Yeah.
We don't have the fact. We don't have the facts to hand to provide the assurance to the board at this point, but we'll take that as way of action.
Thank you, Matt.
It's important to make sure we're all saying publicly that the original programme business case and the outline business case did not include a volume of activity related to research trials. Because we keep describing it, and others keep describing it as we've wanted to retain stuff. Well, the original case and the financial modelling
Never did.
failed
Okay.
to include that.
Thank you.
And the narrative is important because
Yeah.
my team
Let's bring that in.
Yes.
are getting publicly, I know we're in a public meeting, I'm going to say it, Welsh maybe given the perception that Valindra has resulted in, by retaining a reduction in the savings target available. Because
Yeah.
obviously
Yeah.
the whole point, not one of the points is sustainability. And making sure
It
we
was
have a
never in
supply.
scope in the first place.
But the savings were overstated because the R&D trials never included in the financial modelling, but all of the costs were, and assumed that the hub would be doing that by nature, by the fact they didn't take out the staff for R&D production, by leaving them in and then saying that's the new cost. The difference was all declared as savings, but it clearly can't be because we would still have had to do the R&D, retain some of those staff, and not an insignificant number. Because if you think about trials, they're the complex ones that have got to be turned around quickly.
Yeah.
Take disproportionately more time to produce, which is why trams didn't want to do that. They didn't have the skill set. So that narrative is important because it's getting out there as a wrong message, and we need to do.
Okay.
Sorry.
So I think Andy, thank you.
Yeah. Sorry, I was just going to follow up with Matt. This huge cost savings, of course, getting too expensive medicines where you get them through a clinical trial, and that's not factored in. But sorry, we're
No. Thank you for raising it, and I think there's an action for this in terms of both the narrative and the emerging risk. And there is an issue for us about, where we need to socialise that as well, and how we make sure that it's embedded in the narrative that shared services have around this, rather than being separate to that. So, through our own governance processes, we make sure that is part of the story. But we need to write something first and make sure that it's very clear and that, that it's part of that composite view going forward, because I hadn't fully, I wasn't here at the time, and I hadn't fully appreciated that was, what had happened there. So that's really helpful. Thank you, everybody. Jazz, is that an old hand?
Yeah.
Yes. Okay. Thank you. So we now move on to a number of items for noting. I'm going to go through these one by one and assume that they have been read. As ever, if there is anything that jumps out at you that you need to raise, please do so. Otherwise, I'm going to go through them one by one. 7.1 is Trust Seal Report. Are we happy to note that report? Yes. 7.2 Trust-wide Policy Approvals Update. None again.
It's my summary paper, but the policies relate to, I believe, Matt and Jill.
And these are national policies.
Yes, I believe so.
Yes, they are. They're nationally mandated policies.
Not all of them.
No, because we could no longer wait for the national group to sort out the information governance ones.
Okay.
We made a decision because obviously the IAMs were rightly concerned that we weren't updating them, that we've updated them locally. And when nationally there is a agreed position, we will come back and adjust.
Just to interject, with the confidence that actually the person who chairs the national group is our IG
lead in.
Okay.
So we are influencing, but
so handling concerns is a national policy. Policy management is safeguarding is national. Public protection is national. 4 and 5 are national, and 6 is local, which has been put in place with assurance in the interim. Okay. In that case, are we happy to note all of those? Or very much. Public Strategic Development Committee highlight report. Are we happy to note that? Yes. Shared Services Partnership Committee assurance report.
7.3 strategic partnerships update.
Strategic partnerships update. Note that. Yes, thank you. Oh, my battery's running low. I thought it was. Shared Services Partnership Committee Assurance Report. Yes, thank you. 7.6 Joint Commissioning Committee Highlight Report. Anything on that? No, happy to note. Thank you. Any other business? No. In that case, colleagues, we will have our next public meeting on Thursday, the 30th of July at 10 a.m. Thank you all very much for your contributions today, and thank you for fixing the IT for us at the beginning and for all remaining calm and carrying on. So thanks for your participation. This brings the public meeting to a close. Thank you very much.